Hello, and welcome to ASE's webinar series. I am Jennifer Goss, ASE's Medical Education Specialist. Today's webinar is titled ASE Guidelines for Performance, Interpretation, and Application of Stress Echocardiography in Ischemic Heart Disease. Without further delay, let me introduce today's speaker. Dr. Patricia Pellikka is the Betty Knight Scripps Professor in Cardiovascular Diseases, Director of the Ultrasound Research Center, Vice Chair, Academic Affairs and Faculty Development, Department of Cardiovascular Medicine, Consultant to the Department of Cardiovascular Medicine, Professor of Medicine at the Mayo Medical School in Rochester, Minnesota, past President of the American Society of Echocardiography. Dr. Pellikka developed stress echocardiography as a new modality of testing at the Mayo Clinic in 1989 with her publications. This led to the validation and international acceptance of stress echocardiography as a safe, novel testing modality for many cardiac diseases. In 2011, she became director of the Echocardiography Laboratory, responsible for financial performance, strategic planning, overall clinical research, and educational operations and administration for a unit performing 60,000 studies annually and employing over 230 physicians and other staff. In 2016, the Echocardiography Laboratory was elevated to its own division, chaired by Dr. Pellikka, recognizing its growing importance to Mayo's cardiology practice. In February 2018, Dr. Pellikka became Vice Chair of the Academic Affairs and Faculty Development for the Department of Cardiovascular Medicine. In this capacity, she facilitates academic advancement for physician and allied health staff in the department and has developed a mentoring program to promote staff satisfaction. In September 2019, Dr. Pellikka became director of Mayo Clinic's Ultrasound Research Center. The center uses a multidisciplinary approach to advance ultrasound research and therapy and translate ultrasound research into improved clinical care. Dr. Pellikka's current research endeavors include the application of artificial intelligence to predict patient outcomes. She has served as president of the American Society of Echocardiography from 2012 to 2013. She has more than 700 publications, including more than 360 original articles, as well as abstracts, letters, editorials, and book chapters, with an H index of 76. In 2018, she was selected by the Mayo Clinic and confirmed by Mayo Clinic Board of Governors as the recipient of the Betty Knight Scripps Professorship in Cardiovascular Diseases Clinical Research, honoring Dr. George M. Gura. The named professorship is the highest recognition given by the institution for sustained academic excellence. Without further delay, we will start today's webinar, and now Dr. Pellikka will start with her slides. Thank you.
Thank you, Jennifer. Hello, everyone. It's a pleasure to be with you today and to connect with so many people across the U.S. and throughout the world on the topic of ASE guidelines for performance interpretation and application of stress echo in ischemic heart disease. These are my disclosures, which don't particularly pertain to this webinar. I think the main disclosure that I have is that I truly believe that stress echo is a wonderful technique, incredibly versatile and useful for clinical care of our patients. In other words, I'm a true enthusiast. The learning objectives today will be to understand the currently recommended methods for performing exercise and pharmacologic stress echo, to characterize the stress modality-specific differences in left ventricular responses in the presence and absence of ischemia, to appreciate the role of quantitative regional assessment, especially deformation imaging in stress echocardiography, Also, to understand the indications for exercise and pharmacologic stress echo, including its application in children and young adults. To appreciate the requirements for performing and interpreting stress echo and maintenance of competency. And finally, we will interpret examples of stress echo for assessment of ischemia in common clinical settings. Let's go. So this is a list of various conditions that can be assessed with stress echo. Besides ischemic heart disease, we can evaluate diastolic function, pulmonary hypertension, valvular heart disease, cardiomyopathy, athletes' hearts, and congenital heart disease. Of course, we can do these things in combination. We can assess, for example, valvular disease and diastolic function at the same time that we assess ischemic heart disease, and we'll talk about that a bit. But for everything that we don't discuss in this webinar on stress echo in ischemia, I would refer you to the previously published guidelines on the clinical use of stress echo in non-ischemic heart disease, which were published in JACE in 2017. Regarding the methods for performing stress echocardiography, if a patient is capable of performing an exercise test, that is the test that we generally prefer to do. It's simply more physiologic. And in regard to how we perform that test, we like the patient to perform a symptom-limited test. That means that they exercise until they can't exercise anymore, or until we reach one of the endpoints. We don't stop for any particular heart rate or stage of exercise, because sometimes patients experience their symptom at a very high heart rate or high level of exercise, and that's sometimes the case in trained athletes. On the slide is shown the Bruce protocol, which is the most commonly used protocol combined with treadmill exercise, combined with stress echo. You can see that this has stages that are 3 minutes in length, and at each stage, the grade of the incline increases and the speed of the treadmill increases. This shows the metabolic equivalence at each stage of stress. Another form of exercise, which is also excellent, is bicycle exercise. And we also do symptom-limited exercise testing with this type of protocol. You can use supine or upright bicycle exercise or semi-supine, as shown in this example. This is a bed that tilts slightly with the head up and also slightly to the left. It's got a cutout window to facilitate imaging from the apex. A standard bicycle protocol includes 2-minute stages at each stage of stress. The patient pedals at a constant rate of 60 revolutions per minute, and the resistance increases at each stage. An obvious advantage of bicycle stress testing is that we can perform our echo imaging throughout exercise. Therefore, this is particularly useful if we want to get additional information besides wall motion assessment. This is nice if we want to evaluate valvular function or diastolic function or pulmonary hypertension in conjunction with looking for ischemic wall motion abnormalities, because we have more time to acquire our images and aren't trying to get everything in the first minute or minute and a half after completion of treadmill exercise. For patients who are unable to complete an exercise test, the most commonly used form of stress testing, stress echo in the US, is dobutamine stress. And here we're looking for contractile reserve. A particular advantage of this test is that we can determine the ischemic threshold, that is, that heart rate at which ischemia first develops. The standard protocol involves 3-minute stages, and we're monitoring the blood pressure and the electrocardiogram and obtaining echocardiographic imaging at each stage of stress. Dobutamine is increased from 5 to 10 to 20 to 30 to 40 micrograms per kilogram per minute. And in the last couple stages, we give atropine. We use doses of generally 0.5 milligrams, but sometimes in a small elderly patient, we'll use 0.25 milligrams. We can repeat the dose every minute to a maximum dose of 2 milligrams, but we use a smaller dose of 1 milligram if the patient has liver failure or has small body size. Vasodilator stress also works, and this is using adenosine or dipyridamole, and you might preferentially use this if you're looking at perfusion or coronary flow reserve. This slide illustrates endpoints, causes of test cessation, and definitions of abnormal test. It also shows the different parameters that can be obtained depending on the protocol used and the subject of interest. So this is workload, which increases at 2 or 3 minute increments depending on your protocol. We're monitoring blood pressure, electrocardiogram, and the patient's clinical conditioning. Then at rest, we evaluate left ventricular function, wall motion. We can assess the E to E prime. We can look at mitral regurgitation, which may sometimes change in patients with an ischemic etiology of mitral regurgitation. If of interest, we can also assess the systolic pulmonary artery pressure. We do that routinely in our laboratory in patients coming for assessment of dyspnea. And we can look at the right ventricle as well. And right ventricular dysfunction might develop in a patient with right coronary artery ischemia. Depending on our baseline findings and the objectives of the exam, we can decide what to obtain during bicycle exercise and also at peak exercise and in recovery. At peak exercise, looking at wall motion and left ventricular function is generally the most important for assessing ischemia. In recovery, after E and A waves have become unfused, that is, the heart rate has slowed a little bit, we can assess the E to E prime ratio. Diagnostic endpoints are achieving a workload of at least 80% of what is predicted for the age and sex. Marked electrocardiographic positivity is also another indication for stopping, as well as obvious echo positivity and severe limiting chest pain. Other causes for test cessation include intolerable symptoms, muscular exhaustion, severe hypertension, symptomatic hypotension, significant arrhythmias. An abnormal test includes patients with symptoms of angina, syncope or near syncope, or fatigue at a very low workload. Ischemia, of course, is manifested by new or worsening regional wall motion abnormalities. Arrhythmias are another marker of an abnormal test. And then depending on our exercise protocol, an E to E prime ratio of more than 15, pulmonary hypertension, or ischemic mitral regurgitation may also develop. This shows the typical distributions for the right coronary artery in blue, the LAD in ivory, and the circumflex in pink. You can see that this is a 17-segment model, with the 17th segment being the apical cap. We score each segment as normal with a score of 1, indicating normal or hyperkinesis with a systolic increase in thickening of more than 50%, hypokinesis or 2, akinesis or severe hypokinesis as 3, dyskinesis as 4, and aneurysmal as 5. Aneurysmal, of course, refers to diastolic deformation, the thinned pouch out segment of the wall. Although the previous ASE chamber quantification guidelines did not include aneurysmal, our writing group thought it was important to reinstitute this because of the prognostic importance of correctly labeling an aneurysm if you see it. So the segments usually attributed to the LAD are the anteroseptum, anterior wall, and apex. Segments attributed to the right coronary are the right ventricle, basal, infroseptum, and inferior wall. The lateral wall is subtended by the circumflex vessel, but sometimes the anterolateral wall can be supplied by the LAD, and sometimes the infralateral wall by the right coronary artery. Those segments that can be supplied by more than one vessel are shown with the hatched lines. This is the 4-chamber view where we're looking at anterolateral wall and infroseptum, the 2-chamber view where we're looking at inferior wall and anterior wall, and the apical long axis view, similar to the peristernal long axis view, where we see infralateral wall and anterolateral wall. Here is an example of an exercise echo in a 58-year-old woman referred for evaluation of exertional dyspnea. You can see her exercise hemodynamics shown here, heart rate increased to 140, normal blood pressure response. She exercised to 92% of her functional aerobic capacity, or what was predicted for age and sex. Her E to E prime ratio was normal at rest and with exercise, and her tricuspid regurgitation velocity also exhibited just a normal expected increase. Her oxygen saturation, measured in this case because of her symptom of exertional dyspnea, was normal. Here we see, of course, an example of a completely normal exercise echo. At rest, systolic function appears normal, there are no regional wall motion abnormalities, and with the stress of exercise, all segments appear to increase their contractility in a symmetric fashion. Ejection fraction goes up and end-systolic size decreases. Here's the apical 4-chamber view with the left ventricle here, right ventricle here, and the 2-chamber view, also normal. Now we know that in a patient like this, the outcome would be expected to be excellent. These are old data, and these have been shown in multiple studies that if you have a normal exercise echo, your event rate, that is for cardiac death, myocardial infarction, or coronary revascularization, is less than 1% per year. That's very helpful information to have when counseling your patient. The information that we get and how we interpret the study varies a little bit with exercise, dobutamine, and vasodilators. And the selection of the test also varies a little bit depending on the objectives of the test. Now, as we mentioned before, exercise is preferred if the patient is able to exercise adequately, and I often ask the patient if they can walk a mile to decide whether they'd be able to complete an exercise test. Dobutamine is preferred for viability or if the patient is unable to exercise, and vasodilator is preferred if myocardial perfusion is the objective of the test. But this perfusion can be assessed with any of these types of stress. Exercise increases oxygen demand, as does dobutamine, whereas the vasodilator increases myocardial blood flow. We can expect a greater increase in heart rate with exercise and dobutamine. compared to vasodilator, where the increase in heart rate is much more modest. Blood pressure typically goes up considerably higher with exercise compared to dobutamine imaging, dobutamine stress, and goes down a little bit with vasodilator stress. Stroke volume increases very much with exercise. We found when we measured it with dobutamine that it goes up a little bit with the first stages, but then actually goes down a little bit with continued higher doses of dobutamine. Stroke volume does not change much with vasodilator stress. Contractility differs among these. Contractility increases somewhat with exercise, but very much with dobutamine, and doesn't change much with vasodilator. Contraindication specific for exercise is the moderate to severe hypertension, which could conceivably contribute to false positives, severe hypertension for dobutamine, and hypotension or bronchospasm for the vasodilators. Of course, unstable hemodynamics, acute coronary syndrome, or serious arrhythmia would be indications for any of these stress tests. Here's an illustration of ischemia, and we're looking here at end-systolic frames at rest and stress with exercise echo. And this is from patients with left main disease, which we use as a prototype for significant ischemia. In patients with left main disease, we see wall motion abnormalities with stress, and with exercise, we can expect to see the ventricle dilate and the ejection fraction fall. On the other hand, with dobutamine, even with this significant coronary disease, and when we did develop significant wall motion abnormalities, with dobutamine stress, the ejection fraction may not decrease, but may still be maintained despite significant ischemia. And the end systolic volume may decrease despite the presence of ischemia, as shown in this example. So you can't wait for the ejection fraction to fall and the ventricle to dilate when you're doing a dobutamine stress echo, because you will miss ischemia. Here's another example of a stress echo. This is a dobutamine study. We're looking here at baseline, low dose, pre-peak, and peak images, and this is an apical long axis view. This patient also received atropine. The patient had chest pain at peak stress, and the electrocardiogram was normal. I would like you to take a look at this and think about what you are seeing here. This patient had circumflex disease, and I think you can appreciate that there is a subtle area of hypokinesis here at baseline. And although it looks pretty good right here, it's become more prominent at peak stress. So a subtle finding, but this illustrates the issue of, even though this patient had significant coronary disease, the ejection fraction and the end systolic size tend to decrease with dobutamine stress. It's just part of the physiology of this stressor. This graph shows the stress echo predictors of risk. Characteristics of very low risk stress echo would be normal exercise echo in a patient who could exercise well. Perfusion being normal is also a predictor of very low risk, and normal strain. We'll talk about that some more. Risk increases if the patient is unable to perform an exercise test, or in the case of a dobutamine study, if they fail to achieve target heart rate. Increasing risk is also characterized by patients with risk factors, advanced age, male sex, diabetes, prior myocardial infarction. Symptoms of dyspnea and heart failure are also associated with higher risk. Left ventricular hypertrophy, resting wall motion abnormalities, reduced ejection fraction, and of course the presence of ischemia. Patients at the highest risk are those with extensive resting wall motion abnormalities or reduced ejection fraction, and with extensive ischemia, multivessel ischemia, ischemia occurring at a low heart rate, and those with no change or a decrease in ejection fraction with stress. Here is another example of a dobutamine stress echo. This is an example from a 49-year-old woman with diabetes and peripheral arterial disease. She was referred for evaluation of the symptom of throat discomfort. Dobutamine was infused to the peak dose of 40 micrograms per kilogram per minute, and additionally, she received a 1/4 milligram of atropine to augment her heart rate. The electrocardiogram was negative. Please take a look at this. Here's our apical 4-chamber view with the left ventricle here and the 2-chamber view. Images are a little tricky here, but I think you'll appreciate that there are some resting wall motion abnormalities, albeit subtle, involving the apex. With stress, however, you can see that the apex has actually dilated, and the wall motion abnormalities are more extensive. In the 2-chamber view, things look pretty good at baseline. There might be some hypokinesis of the mid-inferior wall, but with stress, we see this severe hypokinesis of the entire apex, extending to involve the mid-inferior wall. And compared to the end systolic size and ejection fraction here, you can see that they are worse here at peak stress. So markedly positive study. And indeed, this patient had 3-vessel coronary artery disease. Now, importantly, the prognostic value of stress echo has been established in various populations, including both sexes, elderly, patients with diabetes, chronic kidney disease, peripheral arterial disease, after coronary revascularization, and in patients with different symptom characteristics. The prognostic value of stress echo has been established with exercise and pharmacologic stress echo and has been shown to be incremental to information you could get from clinical variables or symptoms, the electrocardiogram or stress electrocardiogram, and the rest echo. Here are data about survival in patients who had a left bundle branch plaque and underwent an exercise echo. And you can see that the presence of ischemia did well to differentiate those with different outcomes. A question that often comes up is how stress echo compares with nuclear perfusion. And here's an example of these data. This is nuclear perfusion and stress echo, and you can see that normal and abnormal with either modality performed really very comparably in differentiating outcomes. Our document also addresses the subject of myocardial viability. Viability is what we're looking for when the left ventricle is not contracting normally at rest, and we wonder if it's because of a problem with the blood supply to the heart. This shows the different responses of infarcted or scarred myocardium, stunned myocardium, where there may have been a total occlusion, but the vessel has now been opened, or hibernating myocardium, where the myocardium is subtended by a tight coronary stenosis. At rest, all of these can appear severely hypokinetic to akinetic. No matter how much dobutamine you give, though, the scarred area does not augment its contractility. In fact, it may appear hyperrefractile and thinned with a thickness of 5 to 6 millimeters or less. On the other hand, stunned myocardium, that which has been subjected to an ischemic insult, but the vessel is now open, is expected to augment its contractility with increasing doses of dobutamine. Remember that dobutamine does increase coronary blood flow, and that's how this happens. On the other hand, if you've got hibernating myocardium, it will augment with a low dose of dobutamine, but then as the heart rate increases and the contractility increases with increasing doses, and there's more demand for myocardial oxygen supply, the ischemia gets worse and we see reworsening of function. So we typically look for viability with dobutamine stress echo, but you can also assess it with bicycle exercise if you do a multi-stage protocol and image at low doses or low level of stress. This illustration shows the difference between dobutamine and perfusion imaging, and this is based on a histopathologic study in a small number of explanted hearts where viability were assessed with dobutamine and nuclear perfusion. You can see that if there's just a small area of infarction, both dobutamine echo and nuclear perfusion imaging will register as this as being a viable segment. On the other hand, if it's a bit thicker, this may not be enough myocardium to augment its contractility with dobutamine, will be recorded as not viable with dobutamine, but may be recognized as viable with perfusion imaging. Whereas if you have a very thick layer of infarction, it will be not viable with either. And it's probably this that accounts for the difference between dobutamine and nuclear perfusion imaging. Dobutamine has a higher specificity for predicting recovery of function after revascularization, whereas perfusion imaging has a higher sensitivity. Now here's an example, and I'd like you to take a look at this. 76-year-old woman with dyspnea, prior bypass surgery, and she's referred for a dobutamine echo, and the question is whether there's viability and ischemia. So baseline image here, you can see that there's a resting wall motion abnormality involving the anterolateral wall. It looks like there is some augmentation of contractility with low doses of dobutamine and even with intermediate dose, but at peak, there's ischemia. And we see the same thing here in this two-chamber view. The anterior wall has an area of hypokinesis. It might be augmenting a little bit here, looks a bit better here, although the plane may be slightly different, and then it's clearly gotten worse here. This patient was found to have an occluded diagonal vessel, which accounts for this ischemia in a sub area of the LAD. Here's an illustration of the ischemic cascade. And you can see that when ischemia occurs, the first abnormality that we see are abnormalities of perfusion. Next, we see abnormalities of diastolic function, strain, systolic dysfunction, and only late do electrocardiographic abnormalities and angina occur. So this points out why, if we use imaging, we're going to increase the sensitivity of the test beyond doing an exercise ECG. Perfusion imaging with myocardial contrast echo has not been approved by the FDA, but you can perform perfusion imaging during stress echo, and indeed it has been done so in thousands of patients as part of research protocols and has been shown to improve accuracy for detection of coronary disease beyond wall motion assessment. The method of doing this involves ideally using a continuous infusion. You can dilute the DEFINITY to quite a significant level of dilution, a somewhat less dilution for Optison or Lumison. Very low mechanical imaging works very well. It's the same settings for left ventricular cavity opacification and perfusion. You'll use brief high mechanical impulses, flashes to clear the myocardium, and there's a flash button on most ultrasound systems. And then when you're doing stress imaging, you'll tend to decrease your dose of the ultrasound enhancing agent and also decrease your gain. You can look at the rate of replenishment, which normally is less than 5 seconds at rest, and then the rate of replenishment should be very short with stress. Let's look at some examples of contrast imaging. So this is an unenhanced image, left ventricle here, right ventricle here. You can see that the apex looks like it's probably hypokinetic. We don't see it all that well. Now, when we give low mechanical index harmonic imaging, you can see that there is an apical wall motion abnormality here. However, when we do very low mechanical index and fundamental imaging, you can see not only is there a wall motion abnormality, but there's an apical thrombus. So this really helps a lot. This is an image from our guidelines document. Here's another example from our guidelines document. Rest and stress images. In this apical long axis view, you can see that perfusion, and this is shortly after flash imaging, is normal here. But at stress, you can see that the basal infralateral wall is hypoperfused. And if we look at the time course of perfusion, here's that flash, and immediate post-flash, the microbubbles have been destroyed. 1 second, it's coming in. 2 seconds, coming in 4 seconds, completely normal here at rest. But with stress, the flash is here, and we see that the perfusion never is normal in this patient who had ischemia in the infralateral wall. Another way of evaluating ischemia is to look at global and segmental strain. And I think this really will be very important as we develop an advanced machine learning for interpretation of echocardiography. This is a very useful quantitative parameter. You can see at rest here that global strain was normal, and with stress, it became more negative, an expected response. On the other hand, this is a patient with coronary artery disease, left anterior descending disease specifically. And the resting global strain was -14. With stress, it became less negative, so even worse. And you can see that the segmental abnormalities corresponded to wall motion abnormalities that were appreciated in this patient with left anterior descending coronary artery disease. The last multimodality appropriate use criteria for ischemic heart disease were published in 2013. And I think we can expect that an update to these guidelines will soon become available. But this document, which was a collaborative effort led by American College of Cardiology and multiple subspecialty societies, including ASE, compared different modalities of stress for evaluating symptomatic patients. Different modalities of stress, as well as calcium scoring, CTA, and invasive coronary angiography. And according to pretest probability and whether the electrocardiogram was interpretable and whether the patient could exercise. You could see that stress echo was rated as appropriate in most of these circumstances and may be appropriate in patients with low pretest probability of coronary disease and an electrocardiogram that was interpretable in a patient able to exercise. So stress echo compared very favorably compared to these other modalities for evaluating patients with symptoms. stress echo can also be nicely applied to children and young adults who are suspected to have ischemia. This might be patients with Kawasaki disease and coronary artery aneurysms, as shown in this angiogram. After cardiac transplantation, when there's an anomalous origin of the coronary artery in patients with familial homozygous hypercholesterolemia, prior chest radiation, transposition of the great arteries, and arterial switch operations. All of these situations that might be associated with myocardial ischemia. Remember that stress echo is a nice procedure to administer to children and young adults because you completely avoid the radiation exposure. It's so well tolerated. And children, even fairly young children, can often cooperate well with an exercise test. I wanted to talk a little bit about the symptom of dyspnea. These are old data from our laboratory looking at event rates in patients with dyspnea, chest pain, or the combined symptom. This shows the event rates of myocardial infarction, cardiac death, non-cardiac death, and all-cause mortality. And you can see that patients with dyspnea were indeed a very high-risk group. So very concerning. And this really, I think dyspnea is an important indication or application of stress echo. Let me explain more about that. Well, we can do dynamic diastology with exercise echo. We measure the mitral inflow E, the mitral annulus E prime, and we usually use just the medial E prime, unless there's some reason why the medial won't be reliable, and then look at the ratio of the E to E prime. Now, with exercise, the normal patient is able to increase the stroke volume without increasing filling pressure. The normal heart does this by augmenting its relaxation and developing greater early diastolic suction. On the other hand, if the heart cannot augment normally, the diastolic filling pressure goes up, the E velocity goes up, the E prime does not go up, and therefore the ratio of the two goes up. We have found that by adding this assessment of E to E prime, looking for elevated filling pressure, to our assessment of ischemia, and also adding tricuspid regurgitation velocity, we will increase our yield in patients who are referred to the laboratory for exercise limiting dyspnea. It's also been shown that diastolic dysfunction and the E to E prime are associated with reduced exercise capacity and adverse outcomes. This is easily done with Doppler at the same time you do your exercise echo, and is just a very valuable technique for finding the answers to patients' exertional dyspnea. I mentioned the use of exercise echo in patients with left bundle branch block. Pharmacologic stress can also be used. I like doing stress echo in patients with left bundle when ischemia is a concern because you get so much information about the heart. Now here we can see that the patient has aortic stenosis. Patient had moderate degree of aortic stenosis with a valve area of 1.4 centimeters squared. This patient stopped because of fatigue. In this case, you can see that there's some abnormal septal motion in this example, typical of the left bundle branch block. But with the stress of exercise, this is more than just left bundle. This is ischemia involving the distal septum. And you can see that the anterior wall also becomes ischemic here, seen in the short axis view. Here are the apical views in this patient. Ejection fraction looks normal at rest, but you can see that the distal septum becomes ischemic and the apex the mid to distal anterior wall and the apex. This patient's oxygen saturation was maintained. The E to E prime did go up somewhat, and this patient had significant coronary artery disease as expected and corresponding to the wall motion abnormalities that we see here. Let us not forget the many diagnoses that we can see on our resting images obtained at the time of the stress echo. And of course, none of this has been really taken into consideration when the relative value of different imaging tests are taken into are compared in appropriate use criteria. But as I mentioned, we can assess diastolic dysfunction, we can see valvular disease, recognize pericardial disease, we found atrial septal defects, pulmonary hypertension, left ventricular hypertrophy, cardiomyopathies, and even aortic dissection. This is a patient who had an exercise nuclear perfusion test elsewhere that was read as normal. Patient continued to have symptoms and came to our institution and was referred for an exercise echo. Here are the rest images, and the sonographer was concerned about this dimension of the ascending aorta and possibly a double shadow here suggesting a dissection. And so instead of doing a symptom-limited exercise test, we did a transesophageal echo and found this aortic dissection. So this is a great pickup and certainly a circumstance when you'd rather not be doing symptom-limited exercise tests. It really illustrates the safety of stress echo. Here's another example, a patient who came to the laboratory referred for the symptom of lung burning. That was the patient's description of the symptom, and the patient had elected to see a pulmonologist who did not find lung disease, but referred the patient for the stress echo. The baseline electrocardiogram showed some nonspecific STT wave abnormalities, and here are the images for the patient who came to our laboratory. You can see that at baseline here, the anteroseptum is abnormal, and it looks like the apex is as well. Basal infralateral wall looks good, and in this two-chamber view, we don't see the apex very well. Restrictive hemodynamics were present, concerning in this patient without any history of heart disease. And here are the contrast images. You can see clearly now that the entire anteroseptum is hypokinetic. In the short axis view, septum, anterior wall, anterolateral wall, and the apex looks quite dysfunctional as well. So we didn't do a stress test in this patient. I think we've got the answer for her symptoms of lung burning. Instead, the patient was referred for cardiac catheterization. And here you can see a very high-grade stenosis in her left anterior descending coronary artery. So sometimes all the information is there on our rest images. I mentioned that I would refer to the training requirements for sonographers and physicians for performing and interpreting stress echoes. For sonographers, I think they should have a background of having performed at least 1,000 studies, and ideally 2 years of experience, but perhaps 1 year in some cases. The sonographer must understand the coronary territories, the protocols, and the indications for stress testing. Then they should be paired with an experienced trainer and should perform 100 studies with supervision. They will need to acquire exercise images in 60 to 90 seconds, and sometimes you can practice this during dobutamine studies. The physician should have a background of level 2 training in echocardiography. The physician interpreter must also have an understanding of coronary territories, protocols, and indications. They should have some experience in monitoring stress testing, then should also be involved with interpreting at least 100 studies, and ideally another 100 for level 3. Annually, both the sonographer and physician should perform and interpret 100 studies for maintenance of competency. So in summary, we've described the protocols for exercise, including treadmill and bicycle, and dobutamine stress echocardiography. We've highlighted the physiologic differences and how they impact our interpretation. We've described the role of ultrasound enhancing agents and strain imaging as adjuncts to our conventional stress echo. We've talked about the role of stress echo in patients with dyspnea, left bundle branch block, and in children. We've described the role of the ratio of E to E prime and right ventricular systolic pressure as adjuncts to wall motion assessment. And finally, we've emphasized that we need to look at all the information, including exercise capacity, hemodynamic response, as well as wall motion abnormalities and ejection fraction to optimize patient care. I thank you for your attention, and now let us take your questions. There was a question about in what order do we acquire images in our laboratory, whether we do apical first, then peristernal. So it depends a bit on how the baseline images look. If baseline images are all the same, we do start with an apical 4-chamber view, scan to an apical long axis view, and then a apical 2-chamber view. That is one of the reasons why we do our 4-chamber view in a different way than most laboratories orient their 4-chamber view, because with a simple 90-degree rotation of the transducer, you can see all the segments. Then we do the peristernal imaging. Doing apical imaging also works very well if you use contrast, because sometimes you get attenuation from contrast in the right ventricle. You get attenuation of the peristernal images of the left ventricle. However, if the peristernal images are really nice and preferable to the apical images, those are the images that we would start with. There's a question about whether we are doing right ventricular function assessment by strain. We are doing that as in some patients where we're particularly concerned about right ventricular hemodynamics, patients with congenital heart disease, and patients with known RCA disease, where we're trying to assess its functional severity, but we don't routinely assess right ventricular function with strain in the stress echo laboratory. I think it does have great potential. Certainly one has to decide on what their priorities are, as there's so many things that you can look at. There's a question about looking at multiple cardiac cycles on the workstation, or trying to look at just one versus multiple. That's a good question. Actually, in our laboratory, we use a continuous digital stream of data and are looking at multiple cardiac cycles beginning at peak stress with an exercise echo. So we'll look at this whole digital stream of data. It's sort of analogous to obtaining a videotape of everything, but it's better technology. Some laboratories, though, will compare one rest image to 3 stress images in the same quad screen view, like 1 parasternal long at rest and then 3 parasternal longs at peak stress. I think that is also helpful. I do think that you ideally should be looking at more data than just one beat for each view at rest and with stress. With dobutamine, we look at data from each stage of stress, and that's really essential if you're going to determine the ischemic threshold, the heart rate at which ischemia first develops. There's a question about viability and dobutamine studies and the quad screen view display, and which views should be displayed. Should it be baseline, low, intermediate, and peak, or baseline, low, peak, and recovery? We have found that it's usually between pre-peak and peak that we get the changes can be most prominent. And therefore, our laboratory usually does baseline, low dose, which is 10 micrograms per kilogram per minute, pre-peak and peak. But on our continuous digital stream of data, we also record data from each stage and also another round of imaging in recovery. And then if a patient does have ischemic wall motion abnormalities, we keep looking at those in recovery to make sure that they are resolving and that the patient is okay before dismissing the patient from the laboratory. Sometimes, though, a patient will get to peak heart rate very abruptly after atropine is administered, and then we will have baseline, low dose, peak, and recovery images. And it's just important that they're labeled so that the interpreter knows what they're looking at. There's a question about using real-time perfusion imaging in exercise stress echo. And how long after termination of exercise is it acceptable to acquire images? I think that you can, ideally, we want to get our images as quickly as possible after exercise. We try to get everything within a minute and a half. If there is some delay in acquiring images or some unusually long struggle time, we will comment on that in our report, and that could potentially reduce the sensitivity of the test. But that is extremely unusual. One thing that comes up frequently is whether we can judge the study as adequate if the heart rate drops very quickly in recovery after an exercise test. And we have found that those patients with rapid heart rate recovery actually have a good prognosis. And if we get our images quickly within a minute after exercise, I would still consider that test a highly diagnostic study, even if images are acquired at a lower heart rate. There's a question about why isn't perfusion echo imaging approved by the FDA? You know, the contrast companies have tried very hard to get it approved, but the bar for approval, I think the standards become harder and higher every year. It's important to recognize that dobutamine actually was never approved by the FDA for stress testing either, but clearly works and is accepted. It's hard to explain exactly why or to understand exactly why certain things that we think are clinically helpful aren't approved. I can't endorse doing perfusion imaging as an unapproved indication, but I think that you can actually do it alongside your wall motion assessment if the patient has walls that you cannot see without using contrast, particularly since it's the same settings that you use for wall motion, for left ventricular cavity, pacification, and for perfusion. There's a question about the major difficulty in doing strain on stress echo. A challenge is the fast heart rates, which make the signals noisier. And then also, if you use contrast, that can complicate and make it harder to do strain imaging. Probably, though, strain on just your rest images will include a lot of information, and even doing strain after the heart rate has recovered somewhat if you're doing a stress imaging and measuring strain. There's a question about workflow in terms of integrating myocardial perfusion imaging into regular stress echo. I think that that is a good question. We are still working on integrating it. It does require a team that is familiar with the settings and how to optimize everything. A dedicated team that understands what they're looking for in getting the right amount of contrast in the myocardial wall, and the nursing staff that delivers the contrast infusion appropriately. We think that using an infusion pump and diluting the contrast is particularly helpful. There's a question about contrast for echo. All of the contrast agents work. I think that for particularly difficult patients, Definity may be nice because it is very, very robust and very durable, whereas Optison and Lumason are a little bit less robust, but you're less apt to have problems with attenuation in the distal segments with those agents. I think all can have appropriate applications in certain circumstances. There's a question about how quickly we need to acquire our images. We try to acquire our images within a minute, or certainly within a minute and a half. If there's an unusually long struggle time, that should be mentioned in the report. Then there's a question about whether we do a complete transesophageal or transthoracic echo prior to resting images on all patients. We do a screening test if the patient has not already had a transthoracic echo. We do a quick look at the valves. In all our patients coming with dyspnea, we do the E to E prime and tricuspid regurgitation velocity. We want to make sure, basically, though, that it's safe to do the stress study. And sometimes we do find unusual things on those resting images that preclude or make doing the stress test unnecessary. There's a question about how long we monitor the patients after the stress test. We like the heart rate to be approaching the baseline. Sometimes it just stays up for a long time after the atropine is given with our dobutamine studies, and our staff, if they're concerned about the patient, will ask the physician if the patient can be dismissed. The main thing is that we want to make sure that any ischemic abnormalities on the electrocardiogram or ischemic wall motion abnormalities are resolving before the patient is dismissed. There's another question about stress echo as an option for patients with known ischemia and low ejection fraction. I do think that it is an excellent option for those patients. Nuclear perfusion is preferred by some. Stress echo is nice because you can, again, determine the ischemic threshold. The heart rate at which ischemia first occurs. And so that would be for a dobutamine study. And exercise stress echo can be helpful in a patient with known ischemia and low ejection fraction if you're just trying to assess the adequacy of therapy and patient symptomatology and whether it's correlated with ischemia. Okay, thank you for your excellent questions. Thank you.
Thank you so much, Dr. Pellikka, and to all the participants, thank you and have a great day.